pediatric grand rounds. Dr. Soprano, Joyce, is on vacation, so she asked if I would cover for her today. And the first thing I would like to point out to everyone is this is the first pediatric grand rounds in our brand new auditorium. And so we're so thrilled to have it back in service and have everything fresh and new and nice. So that's my first announcement. Does anyone have a safety moment that they would like to share? It got really quiet. There's got to be a safety moment out there. Tracy, anything in the NICU?
Well, yeah, well, not in the NICU, but personal thing.
Okay.
The high reliability techniques is calculated. So, well, I usually drink regular oat milk coffee. This time I brought a leak-proof container, so I would not be the first spiller.
The first spiller in the auditorium. Thank you. I really appreciate that. And we are going to get lids for the coffee, so that will help too, I hope. So our presenter today, I'm going to introduce Dr. Longo and then have him introduce his co-presenters, Heidi Wallis and Dr. Pasquali. So Dr. Nicola Longo is a professor of pediatrics and adjunct professor of pathology at the University of Utah School of Medicine. Born and educated in Italy, Dr. Pasco received his MD and his PhD in molecular biology at the University of Parma School of Medicine. He also did his residency at Emory University in Atlanta, and he's the professor and division chief of medical genetics here at the University of Utah. So please join me in welcoming Dr. Longo.
Thank you very much for the introduction. And can you hear me? So, I want to introduce the other presenter. The second presenter will be Heidi Wallis, who is the Vice President of the Association for Creatine Deficiency. She has many other titles, and she has been involved with an association that promotes the knowledge of disorder that cause brain creatine deficiency, has been instrumental in trying to adding testing for creatine deficiency to newborn screening program across the nation. And Dr. Marzia Pasquali, who is a professor in the Department of Pathology. She is the director of the Biochemical Genetics and Newborn Screening Laboratory at ARUP and has been instrumental in providing new testing methodologies for identifying metabolic disorders at birth. And this is our disclosure slide, and we will not discuss any product of a commercial entity during this presentation. But what we want to do today is just to give you an idea which disorders are caused by the deficiency of creatine in the brain. So in other words, know which disorder exists, how they are treated, how they are diagnosed, and how they could benefit from inclusion in newborn screening program from early identification. So the first thing that we need to know is what is creatine? But well, first, what we need to fill in. There are we would like to convey you is how this disorder present. In this way, the audience should be able to identify at the end of the presentation how to identify clues that a patient might have some of these conditions. The second thing, which is, I think, one of the most important, is how magnetic resonance spectroscopy, which is something that we can use when we order MRI of the brain in children who have developmental disability, can help us identify patients with some of these rare conditions. Let's go back a moment to creatine. So what is creatine? Creatine is looks like an amino acid, and what it does, it helps supplying energy to muscle and other cells. The name creatine comes from the Greek word for flesh, which is creas, and was identified back in 1832, because obviously it was extracted from meat. and that's where the name comes from. It does a very simple role. We all know that ATP, so the chemical energy in the cell, is produced inside mitochondria. But at this point, once ATP is produced, the energy needs to be transferred to the cytoplasm where it is utilized. How does that happen? ATP will not diffuse out of mitochondria, but what will happen that ATP can phosphorylate creatine to generate phosphocreatine. Phosphocreatine can move into the cytoplasm and function as a phosphor donor for ADP to generate ATP. So in this way, what we do, we are able to transfer high energy phosphorus bond from the place where they are produced within mitochondria to the cytoplasm where they are utilized. Obviously, in the cytoplasm, they will be utilized, for example, for muscle contraction, but in the brain, they have a functional role, which is the one of providing the energy to maintain the electrical gradient within neuronal cell. Electrical gradients are essential to maintain the integrity of neuronal cell and to allow neuronal cell to function. How do we get creatine? We get creatine in two ways. So number one, we obtain creatine from our diet. It is present mostly in dairy product and meat, obviously. But also our body has the capacity of synthesizing creatine. We need to obtain creatine every day because part of the creatine that we have is spontaneously degraded, either creatine or phosphocreatine. They are degraded to generate creatinine. Creatinine is what we measure in the BMP, in the CMP, and obviously, if you have a defect in creatine synthesis, the creatinine might be non-specifically low in patients who are affected by this disorder, simply because, again, the creatinine derives from the breakdown of creatine and phosphocreatine. So one non-specific clue of disorder of creatine synthesis are persistently low level of creatinine in serum of affected patient. So, but as a result of this degradation, every day we need to replace about 1 to 2% of the creatine that it is present in our body. And we do that again as a result of a combination of synthesis of creatine and intake from the diet. One also has to keep in mind that the capacity to synthesize creatine is very low in infant and becomes better as we grow older, simply because several of our enzymatic systems are under developmental maturation. So they are the genes that synthesize this enzyme are expressed much better in older individuals. So children are more dependent on the exogenous source of creatine than adults are. Now, how do we synthesize creatine? Obviously, I'm a biochemical geneticist, and I need to show biochemical pathway. But the way that we synthesize creatine is out of two simple amino acids, arginine and glycine. And the first enzyme involved is called AGAT, or arginine glycine amidinotransferase. This enzyme is highly expressed in the liver and in the kidneys. This reaction leads to the synthesis of ornithine and guanidinoacetate. Guanidinoacetate is then converted into creatine by a second enzyme, which is called guanidinoacetate methyltransferase, or GAMT. What we have that the methyl group of S-adenosylmethionine is attached to guanidinoacetate to synthesize creatine. At this point, once creatine is formed, it needs to be taken up by tissue. And there are multiple creatine transporters, the most important of which is called the creatine transporter 1, or CT1, encoded by this gene, which is called SLC6A8. So by the means of this transporter, creatine will be able to enter inside all cells in the body and also inside the brain, and perform its function until it is degraded to generate creatinine, and creatinine is excreted in urine by the kidney. So in this way, we complete all of the cycle that allow us to synthesize creatine, transfer creatine to all tissue, again including the brain and the muscle, and then degrade the creatine to creatinine that it is excreted in urine. Now, why do we call them brain creatine deficiency syndrome? So brain creatine deficiency syndrome are caused by defect in creatine synthesis or transport, just the pathway that we have just seen. Deficiency if any of the enzyme or the creatine transporter can lead to a brain creatine deficiency. And this disorder presents in a very non-specific way. Children have intellectual disability, autistic-like behavior, low muscle tone, they can have seizure, movement disorder, speech and cognitive delays. And patient can be much more mildly affected and just can have moderate intellectual disability, attention deficit disorder, hyperactivity, and sometimes just a speech problem. You can see from the description of this syndrome, there is nothing specific in that. So in other words, most of the children that we see in a genetic clinic have exactly this type of clinical presentation. There is nothing that can distinguish this patient from the other. Now, what can distinguish, however, them many times they can have intellectual disability or seizure, and many times in the evaluation of children with intellectual disability, we obtain a MRI of the brain to look if there is a structural abnormality of the brain. And most of the time, the brain MRI in these children is completely normal. It can have some abnormality, but many times it's completely normal. But there is something that it is always abnormal in the brain of these children, which is the content of creatine in the brain. How do we measure the content of creatine in the brain? We don't have to do a brain biopsy. We don't have to do a spinal tap. All we have to do is at the time of the MRI, we have to request a special technology, a special procedure, which is magnetic resonance spectroscopy. Using the MRI machine, we can measure the concentration in a semi-quantitative way of the major chemicals that are present in the brain. And this is, for example, a magnetic resonance spectroscopy of a normal control. So in general, what we do, we identify an area in the brain where we want to measure the chemicals. And then we position a voxel. A voxel is like a cube where we want to measure the content of chemicals. And it is like pixel, but it is in 3 dimensions. That's why it is called voxel. And you can see that in this case, it's positioned in the basal ganglia, which is the structure that we usually sample with this type of technology. The major peaks that we see are N-acetylaspartate, creatine, and choline. And you can see that choline and creatine usually have pretty much the same height. Again, this is done in a completely non-invasive manner. So we don't touch the brain of these children. We don't do a spinal tap. In a patient with brain creatine deficiency, what we obtained that the N-acetylaspartate is present, the choline is present, but look at the peak of creatine. It is completely missing or markedly reduced. So magnetic resonance spectroscopy can identify all children with brain creatine deficiency syndrome. It is very simple, and if added to standard MRI imaging, it had very little cost and very little time to the procedure. Now, the first disorder that can cause brain creatine deficiency is called arginine glycine amidinotransferase deficiency, or AGAT deficiency. And it is the most rare of these conditions. There are a total of 16 patients reported to date. These children present exactly like all other with brain creatine deficiency with intellectual disability. They tend to have more muscle weakness than others, or a low muscle tone, and they are diagnosed exactly in the same way. Once the diagnosis is accomplished, the therapy is very simple. We give creatine to them because they cannot synthesize creatine, and this, if started early in life, can completely prevent intellectual disability. And even patients that are diagnosed symptomatically benefit from the treatment because they have an improvement of muscle tone. Now, how do we diagnose this condition? So there are actually laboratory standards for the diagnosis of this condition set by the American College of Medical Genetics, and they involve the measurement of creatine and guanidino acetate in plasma and urine. Again, low serum creatinine in the BMP or CMP can be a non-specific clue to decrease creatine synthesis. So, and this is a clue of AGAT and GAMP deficiency, the two disorders of creatine synthesis. Usually, most of these conditions require DNA testing for the definitive confirmation, and sometimes we have to do functional assay because we identify DNA variants that have never been reported. What do we find in a GAT deficiency? So first of all, the sample that we need to use in a GAT deficiency is to measure creatine and guanidino acetate in plasma, and these are two patients who were actually diagnosed by exome sequencing in their 20s. So they can escape diagnosis very readily. And you can see that the plasma guanidino acetate is 0, which is what you would expect because the enzyme that synthesizes guanidino acetate is completely missing. They have low level of creatine, and obviously this creatine would derive from the diet of this patient. But this is the way of diagnosis this patient. Now let's move on to a specific case that actually was seen here, and this is a child who was noted to be delayed in development. And I saw this child at 1 year of age, and basically she wouldn't move. She was severely hypotonic. She could only blink her eyes. And then she developed seizure at about 2 years of age. The MRI had some non-specific abnormality, but also there was markedly decreased peak of creatine. And you can see that this was the MR spectroscopy of this child, and the creatine peak is absent. You can also see that after therapy, we could restore partially the peak of creatine. Now, this child had a different disease, did not have AGAT deficiency, had GAMP deficiency, guanidino acetate methyltransferase deficiency. And in this condition, what you have, so first of all, this is a little bit more frequent than AGAT. We still don't have a specific incidence, but we think that it is in Utah, we had a frequency of about 120,000 people, but it might be a little bit less or a little bit more. Again, the presentation is totally non-specific. The only thing which is different compared to the other is that many times these patients have seizures that are resistant to therapy with common anti-seizure medication. So seizure can be resistant to therapy. In this case, the diagnosis, what you have low level of creatine, but also increased level of guanidino acetate. Therapy in this case is more complex. Why? Because the pathology is due not only to the lack of creatine, but also to the presence of guanidino acetate. Guanidino acetate is a toxic chemical for the brain, so it impairs brain function. We need to reduce the concentration of guanidino acetate in the brain. How do we do that? The way that we do, we try to limit the concentration of glycine, and we do that by giving benzoate, sodium benzoate will bind glycine and decrease the concentration of glycine in blood. And the second thing, we provide ornithine. Ornithine is produced together with guanidino acetate, and what it will do, it will reverse back the reaction of the AGAT enzyme, the one which is just before the production of guanidino acetate. And the combined therapy seems pretty effective in preventing intellectual disability. The only thing, if a patient is affected, there is only partial efficacy of the therapy. And that it is why this specific condition would be a prime candidate for neonatal screening, because what we can have with this condition is that if we start the therapy early, we can really prevent intellectual disability. What do we see in patients with GAMP deficiency? Again, the preferred sample is plasma, and you see an increase in guanidinoacetate. This is the normal value, and it is many times above the normal value, and also a decrease in the level of creatine in all of these patients. So there is low creatine because they cannot synthesize the creatine, and there is an increased level of guanidinoacetate. You can see that also the urine can be abnormal, but urine testing can miss patients with GAMP deficiency. And that is why the preferred sample for testing is plasma. Now, this is another family that we had a few years ago, and we happened to see this child here when the child was about 3 years of age, and he had global delays, and he had a history of a half-brother from the mother who had the same type of symptom, and he was 12 years old. He also had no creatine in the brain by magnetic resonance spectroscopy. Now, what did this child have? This child had creatine transporter deficiency. And this disease, as you have seen from the pedigree, it is X-linked. So female carry the abnormal gene, but in most cases they have no symptoms. But their boys can have the deficiency of creatine in the brain. In this case, you have that creatine is normally produced, but cannot reach the brain, and that's why there is brain creatine deficiency. The frequency of this condition is unknown, but it is probably more frequently than guanidinoacetate methyltransferase deficiency. The presentation is totally non-specific again, with delays in development, hypotonia, and seizure, and autistic-like behavior. And in this case, the diagnosis will require the measurement of creatine in urine. Why in urine? Creatine will be completely normal in plasma, but the kidney has the same membrane transporter that carries the creatine inside the brain. If it is missing in the kidney, the creatine will be lost in urine. So it gives us a clue that something is wrong with the handling of creatine by the body. In this case, some patients respond to creatine, arginine, and glycine supplement that they promote the synthesis of creatine in the brain, but many patients, we don't have a therapy. And there is one experimental therapy, which is called psychocreatine, which seems effective in a mouse model of brain creatine deficiency, but we still do not have an effective therapy in this condition. And usually these children have a static encephalopathy with seizure responsive to standard therapy. In some families, these children have been confused with children with Fragile X syndrome simply because they have an X-linked pattern of inheritance, and sometimes they look like children who have exactly Fragile X syndrome. Going back to the diagnosis, the preferred sample in this case again is urine, because the creatine is wasted in urine by this patient, and they have an increased creatine to creatinine ratio in urine. And this allows us, together with the brain MR spectroscopy, to establish the diagnosis in this patient. Now, I told you before that some of these patients have a better outcome because some of them do respond to therapy with creatine and arginine. Which patient respond to therapy? So this is a functional assay done in fibroblasts, and in normal patients, so fibroblasts share the same creatine transporter that it is present in the brain, and you can see that creatine transport in normal fibroblasts is pretty high. In patients who have the standard brain creatine transporter deficiency, that are patients 1 to 7 here, creatine transport is reduced to less than 10% of control. We had recently one patient, patient number 8 here, who had about 20 to 30% normal creatine transporter activity, and he actually had a minimal creatine peak in the magnetic resonance spectroscopy. So in this patient, with a variant of unknown significance that have never been reported, we were able to improve dramatically development, speech, and have seizures to stop happening just by giving creatine, arginine, and glycine to promote the synthesis of creatine inside the brain. So obviously, the patients who have milder variant of the creatine transporter deficiency are the ones that are most likely to respond to effective therapy. Other patients do not, and that is why there is active research trying to identify other compounds, such as cyclocreatine, that might be able to enter the brain independently from the creatine transporter. So we have seen a second what are the brain creatine deficiency syndrome. I want to pass the microphone to Ms. Heidi Wallis, who will present her story.
Thank you. So like Dr. Longo said, I am a mother of 4 children. 2 happen to have a creatine deficiency, and I'm the vice president for Association for Creatine Deficiencies, as well as I work at the health department in newborn screening. And our story started in 2003 when my first daughter was born, Samantha, and her birth story was relatively normal. She seemed to be a happy baby. She looked quite normal. She didn't have any outward signs that anything was wrong. And being a first-time mom and dad, we thought she was perfect. When she got to about 18 months of age, she was just slow to hit all of her milestones. Again, nothing really obvious or urgent, but she didn't walk until 18 months. She didn't crawl until she was 12 months. And so her pediatrician was keeping a watchful eye on her and ended up referring us to early intervention. And we started there. We did a lot of home therapies, and by 3, she was referred to Children with Special Health Care Needs. And there she received an autism diagnosis by a 1-point score. So they told us if she had scored 1 point lower, she would not be on the spectrum. And of course, my husband and I left that meeting very confused. She did not seem autistic to us. She seemed just like she was struggling, and we couldn't figure out why. So we left with a sheet of resources and not sure what to do, and we started home therapies and worked really, really hard for the next couple of years, one-on-one with Sam, working on speech, working on potty training. She did get potty trained just before she turned 5. Her speech was very minimal. And she started having little spells where she would stop and look up. And we talked to the people that we were working with for her therapy, and they said, well, she's not verbal, so she's thinking. She stops and she visualizes and she thinks. And we said, okay. And that kind of went on for about 6 months, actually, I'm sad to say. But it started to gain in frequency. And finally, one day she was on a stool getting a cup out of the cabinet, and she did that and fell down. And so we realized we needed to take this to her pediatrician and ask what was going on. So I'm going to share this little home video with you, this is the video actually that I took for the pediatrician. And it also gives you a good idea of kind of her level of speech and cognition at 5.5 years old.
We gonna do some program? What do you think, Samantha? Hey, Samantha, what you doing? Can you say hi? Hi. Say hi. Oh, yeah. Samantha, hey. What are you doing? Oh, are you tired or something? What do you think? That was pretty easy to catch, actually. Yeah, you could give me about 5 of those since you woke up 5 minutes ago. What do you see? You see the beach? Yeah? Oh, keep going. What else do you see, Samantha? An apple? Looks yummy.
So you get the idea. She had some recognizable words that my husband and I could understand, but Mostly at 5.5, she was, severe speech delay. And so the pediatrician quickly referred us up to primaries, and we got in with them. They did the EEG. It was easy to catch. Sure enough, she was having absence seizures. And they decided, let's do an MRI. Let's make sure there's not a structural issue here. And while they were doing the MRI, last minute, they did a spectroscopy. And someone had heard that there was some connection. Maybe we should do a spectroscopy. And on a hunch, they did it. And I saw those results and immediately, of course, Googled, low creatine. And I hoped that it was the treatable kind. And so sure enough, we got a GAMP diagnosis. We went to Dr. Longo, and he did genetic testing, and Samantha's guanidino acetate was quite high, which is probably, a good part of why she developed seizures and why her brain was not thriving. And she was very low in creatine. And so you got a good idea of time of diagnosis, kind of how she was doing. She started a mainstream kindergarten, actually, that was very helpful and inclusive, and the kids all worked really hard with her to help her develop speech. And by about 10 months of treatment, she could string together a 5-word sentence that people could understand. So she needed creatine, and we were on the right track. Today, she is 15 years old, and the school district has classified her as intellectually disabled. She's in a classroom with similar students, but she mainstreams for different fun classes, and she has peer tutors that she adores and wants to sit with at lunch every day, and she's very social and a happy girl. And she does still experience seizures that we struggle. We've tried CBD oil, every fancy new drug that's come out, and we have not quite found the right one. But I want you to meet Sam. Sam, come on up. Can you tell everybody what's your name?
Sam.
And how old are you?
15.
And what is your favorite thing to do at home?
My favorite home is
Do you like to watch movies or color?
color.
Awesome. Thank you, Sam. Go sit down, okay? So after a couple of years after Sam had been diagnosed, we had fortunately had 2 children that did not both inherit the defect. And we had wanted to have a 4th child, and we'd heard that this was treatable from birth, and we went ahead and rolled the dice. And Louis was born in 2011. And sure enough, he had GAMP deficiency. And we began treatment right at birth. You can see he's got one of those little medicine bottles, and we kind of cut the nipple extra large. Like Dr. Longo said, the kids just take over-the-counter products. It's amazing that this is such an easily treatable disorder. This is Louis' 1 dose. He does this 4 times a day, and it's water with creatine, ornithine, and sodium benzoate, and he literally packs it in his little lunch bag. He pulls it out with all his friends and shakes it up and drinks it, and it's no big deal. And so I started him young, and he got used to the fact that he had to drink this yucky tasting stuff, and then the good stuff came right after. So Louis is 6 now. He had cognitive testing this spring, and he scored in the normal range all across the board. He's in mainstream 1st grade at school, and he is not having any therapies or anything right now and seems to be doing great. So meet Louis. Louis, come on up. Okay, what is your name?
My name is Louis.
And how old are you?
6.
What grade are you in at school?
1st grade.
What holiday is about to come up?
Halloween.
What are you going to be?
Lego Batman.
So, okay, you can go sit down. So you can see my passion for reaching out to the medical community and pleading with you that when you see a child with developmental delays, that you look a little bit deeper. The autism diagnosis was not a complete story for our family, and it cost us a couple of years, and those are my hopes. I also am passionate about newborn screening. That's the very best situation for these kids. And I just wanted to share really quickly kind of how newborn screening works legislatively. It's kind of complicated. You would think that this would be a no-brainer. We've been told this is a no-brainer disorder, but it's not quite being screened for everywhere. Federally, there is a committee that advises the Secretary of Health. It's the Advisory Committee on Heritable Disorders in Newborn and Children, and they meet quarterly, and they review disorders to discuss which disorders they will recommend to the Secretary of Health. And they have certain requirements that they have set for these disorders. Some of them are pretty obvious. It has to be a treatable disorder, and it has to be detectable through the blood spot, and it has to be a serious disorder and something that's not easily detected when the baby is born. And in 2016, we visited with this committee, and Dr. Longo had nominated the disorder, and they were just updating their requirements, and they added a requirement that they want to have any disorder that's going to be added to their list to have had one baby diagnosed prospectively through newborn screening. And in fact, unfortunately, Louis, with his vial of blood at birth, just did not count because it didn't prove the efficacy of the system, and they're wanting that. So we're kind of on hold right now. But newborn screening in Utah is a little different story. Every state can make their own decisions whether or not they follow the RUSP. And Utah does not always follow the RUSP exclusively. There is a newborn screening genetics advisory committee that meets quarterly in Utah as well, and they review disorders to consider for Utah newborn screening. And similar to RUSP, they vote to move disorders forward, and the additions that they propose are approved by the Department of Health Executive Director. And in 2015, GAMT was added in Utah. So we've been screening for a few years. Unfortunately, we have not found anyone yet, but every day, I think this will be the day. New York has recently added GAMT, and Michigan is scheduled to add GAMT soon. So it's catching on and moving forward. I want to thank Primary Children's, Dr. Longo, and the neurology department that diagnosed Sam originally, and ARUP for their work in newborn screening, as well as the health department and the Association for Creatine Deficiencies. Thank you.
Okay, thank you. I am going to tell you why, so everything that led to the introduction, to the addition of GAM deficiency in Utah. So we explored the feasibility of adding a GAM deficiency to our panel. And again, the idea was, okay, can we integrate the analysis of guanidinoate acetate and creatine in our routine method? The goal was to add the test without adding a cost. So screening for more condition, for more analyte, without requiring an additional methodology and additional sample. So we did that, and in order to prove the efficacy of this screening, of this method, we started a pilot project. The pilot project was supported by the University of Utah Seed Grant Program and ARUP. we collected, and also the Department of Health was instrumental in providing the sample for the pilot project. We collected 10,000 dry blood spots. 5,000 of them were from infant, from the first screen, so less than 7 days of age, and 5,000 of them approximately were collected at the time of the second screen, so greater than 7 days of age. We performed the screening on this de-identified dry blood spot according to the new integrated method. So we performed the screening, testing for all the analyzed amino acid and carnitine, and guanidino acetate and creatine. Again, the goal of this pilot study was to evaluate the feasibility of screening for creatine deficiency syndrome, especially GAMT deficiency, evaluate the false positive rate, and evaluate also effectiveness of second-tier testing to decrease the false positive result. So this slide shows the result of the values of guanidino acetate and creatine according by age. They were measured during the pilot study. So this, the open circle represent the normal control. So infants that didn't have a creatine deficiency syndrome. The black square represent values from dry blood spot obtained from children who were confirmed to have a GAMT deficiency. As you can see, there is a great discrimination between the normal population and patients with the GAMT deficiency. The other thing that there was an important information from the laboratory point of view in setting up a new screening test is that the concentration of guanidino acetate did not seem to be dependent on age. It was pretty consistent throughout the age of the children that we studied. For creatine, it's a different story. So for creatine, we see that in infants less than 7 days of age, the creatine level with the creatine level overlap with the normal creatine level of patients with GAM deficiency overlap with the creatine level in the normal population. But later on, the creatine level are decreasing. So this led to the introduction of a ratio to evaluate better the result of the screening and looking at guanidino acetate creatine ratio. So as you can see, when we introduce the ratio, we have a better discrimination, again, between the patients, which are now represented by the open circle, and the normal population. So when we saw this result, we decided that in order to call a screen positive for GAMT deficiency, we were looking at two different values. The concentration of guanidino acetate and the ratio guanidino acetate creatine. So patients who are falling, so infants whose level are falling into this quadrant were infants with a possible diagnosis of GAM deficiency. But even with this, you can see that there are quite a bit of infants with who do not have the disease but have an abnormal value. So that's why we decided to go ahead and introduce a second-tier test. What's a second-tier test at the level of newborn screening? Second-tier test is a test which is run on the same sample used for the routine screening, but has targets different analytes or uses a different methodology. And in this case, we are still looking for guanidinoate acetate and creatine, but we are using liquid chromatography tandem mass spectrometry. So we are introducing a liquid chromatographic step to our analysis. So we took all of the sample that were falling into this quadrant, and when we look at this sample with the second tier test, only the sample deriving from the infants with GAMT deficiency ended up with an abnormal result. The reason for this is that when you're using a tandem mass spectrometry without a chromatographic separation, you might quantify multiple compounds that have the same mass. You cannot distinguish them. So that's why you have these false positive results. There are isomeric compound or isobaric compounds that have the same mass as the analyte of interest, and they are all detected at the same time as you detect your analyte of interest. And these can cause false positive. By introducing a second tier test, you eliminate, you can differentiate your analyte of interest from the interfering compound. So this is the algorithm that we proposed to adopt at the Department of Health and at the advisory committee, and everybody agreed. And so we're going to proceed with the screening. Normal results were going to be reported as normal. When there was an elevated guanidinoacetate creatine ratio, this sample was going to be subjected to second tier testing. Normal results were going to be called normal, and the results outside the normal range were going to be, so infants with the results that were outside the normal range we're going to go to confirmatory test to exclude or confirm the diagnosis. So these are the results after 3 years of screening. We have screened a little over 150,000 babies. We have performed almost 700 second-tier tests in infants less than 6 days of age. 47% of these infants were in the NICU, and we had one out-of-range results. The confirmatory test turned out to be normal, so it was a false positive, and probably this was a NICU baby and probably secondary to the treatment. We performed a lot more tests, second-tier tests on a sample received for the second screen, greater than 6 days of age. Again, the proportion, about 40% were NICU babies. One was out of range, and so for a total, and the follow-up testing turned out to be normal. So over 151,000 babies, we had 2, let's call them false positive, with a false positive rate of 0.0013%, which is pretty low. It's not, it's almost zero. And actually, because of this, we are trying to introduce additional ratios that could be helpful in even eliminating this very low false positive rate and get to a 0% false positive rate. So,
thank you, Dr. Pasquali. So in summary, we have seen that defect in creatine metabolism and transport result in intellectual disability, hypotonia, and seizure that are difficult to differentiate from other causes of the same problem. AGAT and GAM deficiency impair the synthesis of creatine and may result in low serum creatinine level that can be a clue that this patient might have a defect in creatine synthesis. X-linked creatine transporter deficiency impair creatine entering to the brain. The diagnosis requires measurement of plasma and urine creatine and guanidino acetate. Magnetic resonance spectroscopy that it is to be obtained together with brain MRI can identify the lack of the creatine peak in the brain. Therapy consists in creatine administration in AGAT deficiency with supplements of ornithine and benzoate in GAM deficiency. Creatine, arginine, and glycine may be effective in creatine transporter deficiency, but many of these patients will require novel therapy. Newborn screening can detect GAM deficiency and can really prevent intellectual disability. And I wanted to thank all of the people who have contributed to this project, including ARUP Laboratories, the Research Laboratory, the Utah Department of Health, the Biochemical Genetics Service at the University of Utah, but most importantly, all patients and their family and the Association for Creatine Deficiency. Thank you. We are open for questions, and you can ask questions to all of the presenters.
Explain why the panel didn't accept the diagnosis of this young man.
So the question is why the federal panel has not accepted the fact that one child had been diagnosed and treated at birth. The reason is that it was not a prospective sample. So in other words, we should have identified somebody of whom we didn't know anything about. So, and that is why we are very excited by the fact that the New York State has adopted the screening. And the reason is that obviously detection of patients depends on how many children are born. In Utah, we have about 50,000 births a year. New York has about 5 to 6 times as many. So obviously, we hope that in the next year, we will be able to identify a child prospectively and to convince the federal panel to introduce this at the national level, not just at the state level. So the question is, if we went back to the blood spot for that child, yes, we did. But the problem still, it didn't count because it was not prospective. So we had a clue that something was going to happen.
Thanks, I learned a lot. Two questions. Does the newborn screening detect other types of creatine deficiency syndromes? And then sort of an unrelated question, are you recommending NMR spectroscopy for any infant, child that has developmental disability?
So Dr. Paul Young has 2 questions. The first one is whether the newborn screening can detect other form of brain creatine deficiency. And the answer is, in theory, it could detect patients with AGAT deficiency for a low level of guanidino acetate, and we are actually looking for it to try if we can identify anybody. The only concern is that the condition is really, really, really rare. So we expect that the incidence is probably 1 in a million. If we find one, then obviously that we would have an answer. We still do not have a screening test for brain creatine transporter deficiency. And the problem is that you need to have an effective treatment for all patients before proceeding to newborn screening. I think that is the therapy advance. The advance in therapy will have us moving in, try to identify a system to identify these patients at birth, probably using a different technology. The second question is whether we are recommending magnetic resonance spectroscopy in every child with intellectual disability. The answer is yes. I think that, adding this type of screening to all children who are having a brain MRI. So in other words, you do not request the magnetic resonance spectroscopy by itself, but you request that together with the brain MRI in a child who has intellectual disability and or seizure.
Nicola, a great talk. I guess one point of information and one question. So the point of information that we've run into in neurology is that a lot of insurance companies will pay for a brain MRI, but not a MRS, and so that's been a problem for looking for patients. And then a second question, or a question related, is whether next generation sequencing, if you have experience with how well that can identify the mutations for the different creatine disorders.
So insurance coverage of magnetic resonance spectroscopy is still sometimes hard to get, and I agree completely with you. Many insurances would cover it when they image the brain in patients with brain cancer, but not with intellectual disability. And I think that a lot of it is due to the lack of knowledge about the fact that many of these intellectual disability can actually be identified by the magnetic resonance spectroscopy. And I hope that some of the insurers listening to this seminar will realize how important it is in these patients. Not just in these patients, it is also useful for other type of diseases, and also to assess the progression of myelination and several other genetic conditions. So it is not just for brain creatine deficiency, which is important, that it is important to obtain the magnetic resonance spectroscopy. The second question is how many times do we identify genetic mutations? So in GAM deficiency, in most cases, we are able to identify the causative variant in most of them. But again, there are about 5 to 10% of mutations that escape detection. We hope to be able to be better effective if we to do functional testing, which are still hard to obtain, especially in creatine transporter deficiency. But obviously, you can always contact us and we can try to identify a research laboratory capable of obtaining the testing for you, confirming or excluding the diagnosis.
Thank you to all three of you for that excellent presentation. A comment, I know in some studies in schools of people with developmental disabilities, it's picked up, both forms are picked up actually more often in that group. So that even though we're looking for the newborn screening prevalence, there is that in the ID population. And my question is there any populations in the world where for founder effects or whatever, the deficiencies are seen more often?
We do not know. So we do not know of any population where it is more frequent. And, but obviously the problem that the disease has only been recently described. It has been around for 10 to 15 years max. So people are still unaware of this condition, and they still do not know how to look for them. I want to thank all of you for your attention, and thank you for attending. And I want to thank especially Mrs. Wallis and her children for being present and showing us a living demonstration of how far we can go with newborn screening and what we can do to promote the health and the life of healthy children. Thank you.